Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. K. Suresh. Sir is MD, DIH, DF, FIAP, FIPHA, FISCD, family physician, public health consultant, Bangalore, and visiting professor of practice at Karnataka. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is fainting spell uncovered, a GP's guide to managing Syncope. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. At the outset, I would like to thank IJCP for this opportunity after talking to the esteemed practitioner who are attending this session. The basic effort today is to look at the common problems seen both in children and elderly people, which is technically known as transient loss of consciousness, or in simple word, people complaining of fainting. Another technical word we use is syncope. So what do we mean by this word? The basic word of temporary loss of consciousness, which is TLOC, commonly known as fainting or syncope, it is a heterogeneous syndrome with complex underlying mechanisms with broader spectrum of presentation in general, both in pediatric clinics and general practitioners clinics in all developing countries, particularly in India. Basically, the complaint would be that fainting or a blackout, it is a distressing experience for anybody. Imagine, just now I was seeing my distant relative daughter in relation. She said this morning when somebody knocked her door, instead of ringing the bell with a thudding noise, she just fainted. Now, these are such episodes leave the individuals confused, disoriented, and concerned about their well-being, which is a very common concern. If it is children, it's not only the patient, it is the parents too. Even the elderly, the same thing happens. So it's not just the patient, but the entire family gets concerned. TLOC occurs at any age, but it's more common in children and in elderly. Basic pathophysiology includes what is called as a sudden drop in blood pressure, where the heart rhythm disturbances are there, or it may be due to neurological disorders. In children, what is called as a situational syncope is common, which has a typical triggers of emotional stress, either pain, prolonged standing, dehydration, the sight of blood mixture, or while swallowing, coughing, or even hair grooming. In elderly, it is more often due to cardiovascular issues or orthostatic hypotension, that is postural hypotension, and other air-related physiological changes. I would like to go through about 8 or 9 cases before we discuss on the issue. The first case is a child of 10-year-old judo player and an athlete participating in running races, etc. She reported to me with frequent palpitation during exercise, which lasted for few minutes before gradually subsiding. Before every competitive sports, either judo or the running race, she is put into a regimen of extreme fluid restriction for 3 to 5 days or even more than that, just to see that she can compete in a particular weight class category. The physical examination in this case revealed nothing much, so we sent her for a cardiology checkup. The investigation, like ECG, 2D echo, were also normal. Since the person had already was on a fluid restriction for nearly 3 days, we put the person on treadmill stress test, wherein the person was able to exercise for 10 minutes and 58 seconds, roughly 11 minutes, before terminating due to complaint of dizziness. Child's heart rate from baseline 72, it increased to 195 beats per minute. Similarly, the blood pressure, which was 115 by 54, progressively dropped to as low as 94 by 50 in the 11th minute. But after resting for about 10 minutes, it again came back to 107 by 56 in the next 10 minutes. Simple advice of not restricting fluid, taking enough fluid and salt intake served this purpose, and the next competition she competed, there was no history of such syncope. So this is fluid restricted syncope, a typical case. The next one is another typical uncommon. We call it as a stretch induced syncope. Here is a 17-year-old male boy complaining of syncopal episode roughly once a month in the last 2 years. But of late, it has increased in frequency. That's why they came to us. During the recent episode, what he was doing was stretching exercises. The patient reported that he holds his breath while stretching himself. He said that such episodes are always preceded by his arm stretching exercises or while reaching something which is kept we diagnose it as a vasovagal syncope caused by unintentional, what is called as Valsalva maneuver during the stretching, and a subsequent tilt table test was done which was negative. This is done to rule out any cardiac problems. He was advised not to hold the breath while stretching and slowly rebuild the stretching exercise while respiring normally. Thereafter, in last 3 months, no such episodes are reported. The third case is another child case which is related to allergy. Here is a 13-year-old girl who has a history of asthma and eczema both for quite some time now. Recently, she complained of a syncopal episode. Whenever she went into exercise, she would get generalized through an ECG, exercise, tomography, and cardiac MRI, all were normal. However, again in this case, a treadmill stress test lasted just 11 minutes with the blood pressure dropping from 142 to 68 to and from heart rate of 151 within 10 minutes into exercise. The blood pressure dropped to 120 by 60 and heart rate increased to 200 beats per minute. The treadmill had to discontinue due to child experiencing dyspnea, chest tightness, and generalized urticaria. This girl was put on antihistaminics over the next few weeks, and the episodes are now resolved. This is a new infant, which is a 10-month-old female baby. A much complicated case was brought with the complaints of cyanosis since birth and failure to thrive. She had developed high-grade fever about 7 months ago. On examination, there was central cyanosis and clubbing of the nails. Cardiovascular system was normal and there was no murmur heard. Hemoglobin was 14 gram, total leukocyte count was 6,700. ECG showed a heart rate of 110, a QRS axis of 60 with no chamber hypertrophy. Chest X-ray revealed a cardiothoracic ratio of 60%, and there was a 2.5 to 2.2 centimeter circular shadow seen in the right lower zone and a non-homogeneous nodular opacities in the right middle and lower zones. This case, as a family physician, I referred it to a private tertiary care facility where an echocardiography revealed a structural abnormality in the heart. An agitated saline injected as a contrast was seen in the left arm, appeared in the left atrium, and after 3 cycles, suggestive of pulmonary AVF. Cardiac catheterization revealed normal pulmonary arterial pressures and systemic arterial desaturation. Selective pulmonary arterial angiogram delineated multiple large AVF arising from a hypertrophied branch of right pulmonary artery. The lower lobe branch fed the largest AVF and left pulmonary artery was normal. The case was diagnosed as pulmonary AVF. Unfortunately, we could not save the child despite a surgical intervention. From these 4 or 5 cases of children, we can synchronize a case study which reviewed 30 children from hospital record with laboratory details presenting with real or apparent syncope. There were 5 diagnostic categories considered: neurocardiogenic syncope, psychogenic pseudosyncope, cardiac syncope, neurological, and indeterminate syncope, 5 categories. In children, the study inferred that the neurocardiogenic syncope is the maximum to the tune of about 63%, followed by psychogenic pseudosyncope, which is around 13%. Cardiac causes were 10%, neurological similarly around 10%, and about 3% were indeterminate. We could not be diagnosed. Exercise loud noise, emotional triggers, and family history were associated with cardiac etiology. Mostly electrocardiogram was diagnostic in majority of the cases. Children with PPS and cardiac syncope had frequent episodes when compared with other groups. Indiscriminate anti-epileptic drugs was reported in 5 children, and among them 2 were cardiac cases. So the study inferred that frequent recurrences of syncope suggested psychogenic pseudosyncope or cardiac cause. Cardiac etiology is easily identifiable on the history and ECG. Now we get into some adult and senior citizen cases. First one is my own case due to diabetic orthostatic hypotension. My age is around 81. I'm diabetic since 1994. I had CABG and post CABG angioplasty just a year ago. There are occasions where I get these episodes once in 2 to 3 months, particularly when I sit on the ground floor, when I go for shopping, particularly vegetables in the what are called as rural areas. They are sitting down, so you need to kneel down or sit down to pick up. Or even at home, if you sit down and get up, I get this 10-15 seconds of dizziness, but I have made it a habit to take some support of the wall or a table or a chair which is close by, and in the next few seconds, I will be fine. Then my normal BP, because I am on many drugs for hypertension, is around 135 to 60 to 70. During this episode, it drops down to 100 by 50. All biomarkers, cardiovascular and neurological imaging investigations are normal. So basically, in such cases, diabetic postural hypertension can be managed by the patient themselves taking. The next case is a syncope secondary to arrhythmic ventricular cardiomyopathy. This is a 60-year-old rural lady who presented into a tertiary private care hospital with the syncope when she was walking along with her friends in the evening stroll. She was known diabetic and hypertensive for the last 2 decades. Both were not well controlled due to irregular medication. She complained of palpitation for a week. She could not recall the syncopal episode fully herself, but was supported and informed by friends who were walking with her. Since it's a tested hospital, apart from ECG, which showed normal sinus rhythm, right axis deviation, and right bundle branch, endovascular MRI was done, which showed preserved biventricular function, mild biatrial dilatation, and features suggestive of atrial fibrillation and ventricular cardiomyopathy. She was put on bisoprolol and had an implementable cardio defibrillator, after which she is doing fine now. Now we get our case, which is due to carotid sinus syndrome. This is a 50-year-old, 58-year-old male coming to OPD with similar complaint of basically here is a guy who had undergone treatment for cancer with head and oncology, and their discharge report read that there was a swelling in the left mandible and a MRI was encroaching on the carotid space, indenting on the carotid arteries. The initial oncological report was it was a squamous cell carcinoma. Since the mass was not surgically resectable and the patient did not tolerate chemotherapy, he was put on palliative management. Now, she came to a clinic where the doctor had undergone a recent palliative course. That's why they thought they may be able to get things done nearer their home. Since chemotherapy was stopped, all fasting blood glucose, liver enzyme, serum, everything were normal. So she is now under just a palliative management of only on the admission in the hospital she was referred. The heart rate was was 48 per minute and blood pressure was 90 by 70. ECG was normal. Echocardiogram also was normal left ventricular structure and functions, but computed tomography scan of the brain and thorax were normal. No metastatic lesion were found. A cardiac consultation led to crisis. A detailed evaluation indicated a left carotid sinus syndrome, which is an exaggerated response to carotid sinus baroreceptor stimulation and results in dizziness or syncope from the transient diminished cerebral perfusion. In this case, mechanical deformation of the carotid sign had led to an exaggerated response with bradycardia and vasodilation. The patient is under the care still. We need to see where it goes. Third one is an young adult of 21-year lady presented to an outpatient in a medical college hospital for loss of consciousness for about 20 seconds that morning and a week ago also. Similar histories were reported in the last 6 months preceded by palpitations. Her episodes were aggravated either during hot weather or exposure to hot water when she takes shower or loud noise. She was highly stressed due to a failing matrimonial negotiations since years and was also anxious, for which she was under neurologist and was on these psychotropic drugs. 34-year-old, where the 2 weeks history of losing consciousness during or at the end of a bout of cough, which lasted for 30 to 60 seconds. And there was also a history of jerky movements during the episode, but there was no history of incontinence or tongue biting as it happens in seizures. Chest X-ray and pulmonary functions were normal. 2D echo suggested mild concentrating left ventricular hypertrophy with ejaculation factor of 60. He was a chronic alcoholic weighing 97 kgs and BMI was 32.4. The clinician who witnessed a syncope during the consultation wrote his systolic BP showed a reduction of 110 to 80 and diastolic BP from 70 to 45. Face became congested and he lost his consciousness. The blood pressure returned to baseline as soon as the cough episode resolved. CEC teaches was normal except for an incidental finding of osteochondroma on the third and fourth right thoracic ribs. Symptomatic management of the cough was done, which led to relief, and the person continues to manage the cough as soon as he gets, and now he is not reporting any syncopes. Now, this leads us to a basic discussions. As we have come across all these cases, the first set of symptoms are basically what we call as blacking out. Suddenly you see there is nothing in front of you, or feeling lightheaded. You may fall for no reason, feeling dizzy, or feeling drowsy or groggy, fainting, as I told you, my daughter who came this morning, suddenly after thud of a noise and opening the door, feeling unsteady or weak when standing, as it happens to me, changes in vision, such as seeing spots, tunnel vision, and headaches. These are some common complaints you may hear. And basically, etiologically, we diagnose syncope into two categories. The most common one are reflex mediated, which is about 60%, and orthostatic. Less common are arrhythmias of the heart and cardiovascular structural problems. So, in the reflex mediated, we call it vasovagal, situational, which is more common in children. Vasovagal is more common in both. Carotid sinuses basically in adults. In orthostatic, it is volume depletion when there is a dehydration for whatever reason, drug induced, or an autonomic failure like it happens in diabetes. Arrhythmias and valvular problems are the other etiologies. Basic pathophysiology, as we can tell, is we know for sure that when a person stands from a sitting or sleeping position, the blood pools into the lower extremities, potentially leading to a drop in the blood pressure and reduced flow to the brain. So a normal body to counteract this activates sympathetic nervous system that constricts the blood vessels and increases the heart rate to maintain blood pressure, and the muscles pump, and the non-uniform distensibility of blood vessel helps return blood to the heart. Most cases of syncope are reflex, we already told, followed by orthostatic, arrhythmia, and cardiovascular reasons. The mechanism of BBS, here we do not know afferent how the message goes for this vasovagal reflex. But the process is an autonomic control and central processing is not fully understood so far. However, the efferent message comes as a part of reflex is a clear hypotension and bradycardia due to inhibition of sympathetic system and specific activation of the parasympathetic system. These reflexes usually occur during regional anesthesia also, or when there is a huge bleeding scene, compression of inferior aorta in the supine position. Hypotension and bradycardia disrupt the cerebral blood flow, resulting in sudden loss of consciousness and postural tone. Vasovagal is divided into two categories. One is a classic, where you see the signs which I already quoted. In the non-classical version, there is no obvious precipitating event, but it is diagnosed only on the clinical criteria or excluding other causes of the syncope. Orthostatic postural hypertension is a condition where the blood pressure drops significantly upon standing. I have told you already my own case. Here, one thing to remember diagnosis based on only on recording BP in different position. Unfortunately, the practice of taking BP in three position rarely exists. So in the syncope cases, if there is a difference of 20 millimeters of mercury in systolic and 10 millimeters of mercury in diastolic in different position, this is indicative of orthostatic hypotension. Basically, this is seen as an aging heart finds it hard to speed up to make up the drop in the blood pressure. This is very common on people aged 60 years or more, where the aging heart and neck arteries are unable to control the blood pressure due to the as we age advances. There are medications used like diuretics, alpha blocker, beta blockers, etc., which also disturb the blood circulation and may cause postural hypertension. In addition, there are certain nervous system diseases like Parkinson's, metabolic diseases, almost all vitamin deficiencies which lead to neurogenic cause hypotension. Recurrent syncope is a common feature in the elderly which need to be more careful. One study quoted of 70 cases with 50 control has inferred that this occurs mostly in the male as 80% of the cases are seen in male and the mean age was 80 years plus. Therefore, you see people like me who are crossed 80 are some of people at higher risk. In the syncope group, there were over 42% who had cardiac arrhythmia, 30% had valvular disease. Recurrent syncope was significantly associated with lower scores on what is called as a Montreal Cognitive Assessment Scale. Four or more comorbidity, they had multiple conditions and hearing impairment. Their study also concluded that recurrent syncope is significantly associated with cognitive impairment and comorbidities like hearing impairment. Conduction abnormality was the most common etiology for recurrent cardiovascular syncope. Structured evaluation need to be done to come to a conclusion. So, what should a general physician or a general practitioner do? We'll come to do what is how do you diagnose and manage or refer. Management includes first referring high risk people, managing if they are not high risk, and what is the prognosis. Prognosis in any case in all conditions is similar. So, as a family physician, the golden rules one has to follow is first decide if the patient needs an urgent. This is based on taking a good history regarding the vasovagal prodrome symptoms like headedness, dizziness, coming on standing, blurring vision, etc., which we have already gone through. And orthostatic, as I told you, the only proof there is documenting or recording the BP and pulse rate. Limited monomyoclonic jerking incontinence of less than 10 seconds of post-episode confusion is seen in syncope, in contrast to seizures, where the loss of consciousness is more than 30 seconds. And there is a tongue biting or post-episode confusion indicative of seizure. So there is a differences between syncope and seizure. One need to try to differentiate. Most low-risk syncope can be identified from the initial history, physical examination, and an electrocardiogram. There is also a system developed which called as a risk scoring system to identify, which is called as well score. I'll come to that later, which rules out pulmonary embolism and DVT. Neurologic testing is only required only if findings are concerning of neurological cause like seizure or a stroke. Echocardiogram is preferred for indoor patients where ECG does not reveal anything. If case is not clearly a low risk or a high risk, that means if you are not able to decide, better use the simplified well score and decide whether you need to refer or not. In addition, the investigation done in the institutional setup is D-dimer test, combined approach, that is D-dimer and the PE test. High-risk patients which score more than 4 scores in Wells test usually do not receive a dimer test. That means they are not restricted. They can be directly referred. In PRC rule, if the PTP is low, using well score, then PRC rules can be applied. A well score of 4 or less combined with a negative DNA test can safely rule out pulmonary embolism. Troponins are indicated to manage these cases. Now, once you decide the reference is not required, what do you do? If you have to do, focus is on thorough history and physical examination. I am repeating time and again. First aid during an episode, basic investigation of ECG, urgent referral if needed. If not needed, then go ahead with managing, like first counseling the parents, increasing the fluid and salt intake, behavioral modification. I told you the exercise, person stretching, holding respiration, etc. And even if these things do not materialize, refer again. Now, what is pulmonary embolism rule? Here, it is not for syncope per se, you are ruling out pulmonary embolism. There are these 8 criteria used when the age is less than 50, pulse rate is less than 100, saturated oxygen is less or more equivalent to 95% or more. There is no hemoptysis, no estrogen use, no surgery or trauma, no prior venous thromboembolitis, no unilateral like so. If none of these are there, you apply this Wells test and use. Now here, the Wells criteria gives basic here clinical signs, which we already said. If there is yes, the score is given 3. If P is diagnosed or equally likely, then again 3. Heart rate more than 100, 1.5. Embolization at least for 3 days, 1.5. So if these pitfalls are not there, then you use the scoring rate. And how do you give the score? If there is an active cancer or a treatment done recently, you give 1 point. If person is bedridden for more than 3 days or has undergone a major surgery in last 12 weeks, 1 point. Calf swelling of more than 3 centimeters compared to the other leg, measured 10 centimeters below the tibial tuberosity. Again, 1 point. Collateral superficial veins, again 1 point. Entire leg swollen, 1 point. Localized tenderness, 1 point. And pitting edema, 1 point. If any of these become positive and the score is 4 or more, you better refer the case. When you decide to maintain or manage the case at your level, we have already told initial assessment is very crucial to take a decision. Second important thing is differentiate syncope from seizures or hypoglycemia or psychiatric disorders. During an episode, follow these basic first aid. Encourage the child to lie down or sit down with their head between their knees to increase the blood flow to the brain. While lying, elevate the legs slightly. Loosen tight cloths if there are any round the neck or the waist. Allow the child to stay on the ground until it is fully awake and reoriented. Medications are rarely required. If required, they are required as a consecutive adjunct therapy only when the above things fail. So, if you have to use, it is fludrocortisone, Floricart or Tyroflu, or midodrine 2.5 mg is used to increase the blood volume and improve the blood pressure. Other medication may be considered only depending upon underlying cause. Urgent referrals, as I told you, is the key for referring. When do you do that? First thing you must do is if you are suspecting a cardiac cause or a child is having frequent or prolonged syncopal episodes, there is a cause of syncope remains unclear to you, it is accompanied by neurological symptoms like seizures or prolonged loss of consciousness, then first thing you must do is refer. If you are referring, first you need to rule out the urgent referral, then encourage adequate dehydration with water, salt intake. If a child cannot take orally, give them IV fluids. Make the weather conducive with coolers or AC activity. Minimize strenuous activity if the child is, or person is doing any activity. Advise them to sit down, as I already told you, or even stand up slowly when get up, and be careful when they need to stand up for prolonged position, and may avoid dehydration. Identify and avoid situations like activities that seem to precipitate syncope. They already know what is likely to happen. Most important in the long run is a recurrent syncope has psychological well-being effect. So counseling both the child and the parents is very important. In the long-term management, one look at modifying their lifestyles, if needed, use of medications and regular follow-up with you. With this, I end my discussion, and if there are any questions, you are welcome. I hand over to JSP coordinator.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Please.
Uh, so, sir, the first question is, what are the red flag signs in the syncope that should prompt immediately referral to the cardiologist or neurologist?
As I told you, cardiological symptoms, ECG is the best thing to do. Clinically, one, if there is a family history or an already diagnosed condition. ECG, if the person can read, they most often they give the clue to the cardiological problem.
Next up, sir, how do you risk stratify a patient with syncope in primary care? So, am I audible to you? Hello? So, your video is not moving. Am I audible? Hello? Sir, I hope
Hello?
I'm audible to you.
Hello?
Yes, sir. Can you hear me? Hello?
Disruption here.
Yeah. So I was asking you another question, which is how do you risk stratify a patient with syncope in primary care?
Hello?
Hello?
Is there an electrical disruption this end?
I think,
You
sir,
can
there
ask
is
the
a
second
network
question
issue
again, please.
from your end. So, am I audible to you now? Hello?
Hello.
Hello, sir. Am I audible now?
Hello. Am I audible?
Yes, sir. You are audible. Am I? Can you hear
There
me?
is an electrical disruption here.
Okay, because of which I think you can't hear me, sir. So, am I audible? Hello? I think sir has lost connection with us, because of which he can't hear me or anyone. Anyway, with this, I would like to conclude today's session. As there's some technical issues, I would like to apologize to all the audience for this glitch. So, hope to see you soon for our next session. Thank you.